All right, so I'll go ahead and get started, and I'm going to apologize. My house has been sick for over a week now. I don't know what we had. It was not COVID, but it's taken forever to get better. So my voice is not what it normally is, and I'm coughing. So I do apologize if I have to temporarily mute. So um, ironically, I'm speaking about management of chronic cough today. So let's go ahead and get started. So just to start, I do receive grant funding from the Dorney Koppel Foundation, the Benedum Foundation, and the Carolyn Haas Trust. And this is all for our pulmonary rehab program at Preston Memorial Hospital. I also serve as the consulting pulmonologist for the Partners in Health Network on behalf of the Appalachian Pulmonary Health Project. Next slide. So our objectives today are to define chronic cough, to discuss the cough reflex arc, outline causes of chronic cough, and discuss why it's important to evaluate for chronic cough, to discuss the principles of treatment, and then how to manage unexplained chronic cough. Next slide. So first, definitions. What is a chronic cough? An acute cough is a cough that lasts less than 3 weeks. Subacute lasts anywhere from 3 to 8 weeks, and then a chronic cough is a cough that has been present and lasts longer than 8 weeks. Next slide. Um, so, cough is sometimes a difficult symptom to treat, to evaluate, to determine the cause, because it's not a unique disease, but it's symptoms that can be related to many different medical conditions. It does affect somewhere between 10 to 12% of the population, and it seems to affect females more often than males in a 2-to-1 ratio. Next slide. So, vigorous coughing, you can achieve intrathoracic pressures of 300 millimeters of mercury. And we see that expiratory velocities can approach 500 miles per hour. And I thought this slide was really interesting, showing why we're so concerned with airborne spread of things, especially with diseases such as COVID and influenza. You can see the cough pattern in the picture below. Um, Cough, in addition to traveling such far distances, is also responsible for mucus clearance, but it can also lead to some complications such as exhaustion. People become self-conscious. It can keep people awake. It can cause headache and dizziness, some musculoskeletal pain and hoarseness. Some other less common symptoms such as excessive perspiration, urinary incontinence. Sometimes patients just feel, something's wrong. I shouldn't be coughing like this. Cough is not normal. Something's got to be wrong. We have also seen cough-induced rib fractures and syncopal episodes. Next slide. So the cough reflex arc, there are mechanical cough receptors that are stimulated by triggers. These signals are afferent signals. They're carried by the vagal A delta fibers that are located in the nodose ganglion. There are also chemical receptors that are triggered with ion channels. And these are things like heat, cold, chemical irritants. These signals are carried by the vagal C fibers, and they're located in the jugular ganglion. These afferent signals travel to the cough center in the medulla, where an efferent signal is generated. It travels down the vagus to the phrenic and the spinal motor nerves to the expiratory musculature, which then produces the cough. I think the next slide gives a picture diagram of this. It's a little bit maybe easier to understand. So again, you've got these afferent signals, whether it's pain, heat, cold. There's receptors in the esophagus and the pleura. They travel to the cough center, which then produces this efferent signal that goes down to the vagus nerve, the spinal motor neurons, and the phrenic nerve to then produce this action, which is the cough. Next slide. Excuse me. So the cough reflex arc explains our acute cough. But, it doesn't necessarily explain the full spectrum of what happens during a patient or in a patient with a chronic cough. There is some thought that these patients may have some cough reflex hypersensitivity, where even low levels of exposures can trigger cough. Things like eosinophilic inflammation, reflux, air pollution, cigarette smoke, and just a low level of exposure to these stimulants can actually be enough to produce a cough in these patients. Next slide. So some of our acute causes of cough include upper respiratory tract infection and lower respiratory tract infection, exacerbation of underlying lung disease such as asthma or COPD, interstitial lung disease, reactive airway disease syndrome, tuberculosis, or lung cancer. Subacute causes of cough, usually what we see most often, especially in clinic, is a post-infectious cough. They've had one of these things in column A, and it's sort of hung on a little bit longer. Again, exacerbation of underlying lung disease also can fit into the subacute, and then pertussis. Next slide. You can see our causes of chronic cough. Again, we see our chronic lung diseases such as asthma and COPD can cause a chronic cough. We also see things like non-asthmatic eosinophilic bronchitis, reflux, upper airway cough syndrome, which most often is due to postnasal drip, bronchiectasis, neoplasm or foreign body, interstitial lung disease, lung abscess, patients with recurrent aspiration. And then we also want to think of things that are outside of the respiratory, the pulmonary system, such as chronic heart failure, irritation of the vagus nerve. And then there are some diagnoses of exclusion. So everything else has really been ruled out to the best of your ability. And then we're left with things like somatic cough disorder or chronic refractory cough. So this diagram was pulled from Up to Date, and it talks about how to evaluate for a subacute or a chronic cough in adults. So again, subacute or chronic cough, it's going to be anything that's been happening for longer than 3 weeks. Again, you want to get a history and a physical exam. If it suggests right out, some other etiologies such as postnasal drip, asthma exacerbation, reflux, go ahead and treat accordingly. If the cough gets better, you're done. If the cough persists, then we want to do a little bit of a further workup. If your history and physical exam do not strongly suggest anything, we can also move on to additional workup. Excuse me. If you have symptoms such as purulent sputum, you've got somebody who's a smoker, somebody who's receiving treatment with medications such as ACE inhibitors, or somebody that's immunocompromised. Again, you want to think about what the most possible causes are in these patients. Could stopping the medication help? Do they need an antibiotic? Again, you treat them accordingly. If the cough persists in all 3 of these cases, the next likely step is a chest radiograph. If the chest x-ray is abnormal, then obviously you want to look at what that abnormality is and see if that leads you down any direction and then treat accordingly. If the treatment does not work and the cough persists, or if we have a normal chest x-ray, we want to then move on to treating for the most common causes of cough. And then sort of start ruling things out. We want to look at things like upper airway cough syndrome. Do they need allergy testing? Do they need a CT scan of their sinus? Do they need PFTs? Do we need to get sputum samples or pH monitoring? And you slowly work through that list, treating accordingly. If the cough resolves, we've got an answer. If the cough persists, then you want to move on to those less common causes. Do they need a CT scan? Do they need an EGD? Do they need a bronchoscopy? Any cardiac studies? And then once you've systemically ruled everything out, then you're left with, could this be a psychogenic cause of cough? So that sort of takes you through that diagram. We can move to the next slide. So again, the most important thing to do is to exclude serious underlying illnesses, things that need urgent attention. Do the patients have any B-type symptoms? Are they losing weight? Are they coughing up blood? Do they have any fever or night sweats? do we have concern for some type of chronic infection, some type of cancer, rheumatic disease, something like that that's causing severe symptoms? Do they have purulent sputum? Do we need to consider a course of antibiotics? Again, hemoptysis can be seen with infection, with cancer, with heart failure, with a foreign body. Do they need a CT scan or a bronchoscopy? Are patients having severe dyspnea associated with their cough? Could they have an airway obstruction or some other type of parenchymal disease? And then is there any immunosuppression? Do they have a risk factor for tuberculosis or some other type of opportunistic infection that may move swiftly or be easily transmitted that we need to isolate and treat? Next slide. The most common causes for chronic cough are going to be asthma, gastroesophageal reflux disease, upper airway cough syndrome due to rhinosinusitis conditions. Next slide. So when you start your clinical evaluation of these patients, you want to determine the characteristics of cough. Is it a barking cough? Is it a dry cough? Are they making mucus? How long have they had the cough? Are there any other symptoms? Do they get diaphoretic every time they cough? Is it only a morning cough? Have they had this before? Any new medications, anything like that? Is there any family or personal history? Do they have rhinoconjunctivitis? Are they smoking? Are they vaping? Do they have some other type of occupational exposure? Have they been in a recent fire? Have they traveled anywhere? Any type of history that may help to isolate why, we have this, new type of chronic cough. Again, chronic is 8 weeks, but what has happened over the last 8, 10, 12 weeks in this patient? During physical exam, we want to look for things such as nasal congestion. Do they have any pharyngeal erythema, some tonsillar swelling, hoarseness, stridor, wheezes, crackles, anything that may help to give a better picture as to whether they've got some congestive heart failure that could be causing this, or if they've got allergy symptoms or something else, stridor, possibly a foreign body. Is there anything on exam that can help us narrow down the cause? Next slide. So as far as diagnostic testing, a chest radiograph is pretty routine. You want to make sure that, number one, you're not seeing an abnormality on chest x-ray that could point us in a different direction. Do they have a big pneumonia? Do they have a foreign body? Do you see a large mass in their chest? What is going on? It's not necessarily routine to do a CT scan. However, if you see something abnormal, that may point you in the direction of needing to do a CT scan for some further evaluation. If patients don't have a known history of lung disease, it's worth considering pulmonary function testing to see whether they have asthma or COPD. And then I've mentioned this a couple of times, but a medication list review. Common causes of medications that can cause cough are ACE inhibitors, which I think everybody thinks about on a regular basis. But calcium channel blockers can also cause cough. Bisphosphonates are also common to cause cough. And ARBs can cause cough. A lot of people think, well, the ACE inhibitor caused the cough, so I'll switch them to ARB, but you can still see a cough in patients taking ARBs, and it's actually somewhat more prevalent in patients that developed a cough on an ACE inhibitor, that they would be more likely to get a cough on an ARB. So keep that in mind as well. Next slide. Excuse me. So the principles of treatment for patients with chronic cough, it's common to do a diagnostic trial for common causes. So, GERD is a common cough or common cause of chronic cough. So it's not unlikely or unheard of to put patients on, a month or two trial of medications for GERD. Same thing with allergies and postnasal drip, putting them on a nasal corticosteroid or some other type of allergy treatment to see if this improves symptoms. The recommendation is that you treat one condition at a time. If there's some partial improvement, it's okay to add treatment for a second condition. Most of these patients, it's not as simple as, it's just my GERD and that's it, and that's what caused the cough. A lot of patients have components of that with allergies, with their underlying lung disease, and so it does take multiple different medications sometimes to help this cough resolve. And again, as stated here, some patients' cough will not resolve until all the causes are fully treated. If the cough is particularly debilitating, it is acceptable to treat simultaneously for multiple causes with empiric treatment. If this patient is not sleeping, if they're missing work, if they're having syncopal episodes, it's not unheard of to sort of throw the kitchen sink at them and start them on multiple different treatments at one time. And then, you can, once you get this under control, can sort of back off and sequentially discontinue these treatments. So first you're going to stop GERD treatment, or first you're going to stop allergy treatment and see how they do with that. And if the cough starts to reappear, you can imagine that treatment was doing something, and go ahead and restart that. So just depends, on an individualistic approach as to how debilitating the cough is for the patient. Next slide. So we're going to move on to some specific causes of cough and discuss those in a little bit more detail, starting here with asthma. So we see that asthma can be the cause of cough in about 25 to 30% of our adult non-smoking patients. It can be associated with dyspnea and wheezing, but cough can also be isolated in these patients, and that's usually what we call cough variant asthma. These patients would benefit from evaluation with both a pre and post bronchodilator spirometry. Occasionally, if their spirometry is not conclusive, we can send them for a methylcholine challenge or bronchoprovocation testing. And then they also benefit from a trial of an inhaled bronchodilator. Keep in mind that sometimes your inhaled bronchodilators can take up to 3 months for you to see the full benefit. So it's something I often remind my patients, don't get discouraged if you take 3 or 4 doses of your inhaler and they don't seem to be working. Keep up with it and really give it a good trial. Next slide. Next is non-asthmatic eosinophilic bronchitis, and I apologize, this is a really busy slide. So this cause of cough is responsible for about 10 to 30% of patients with chronic cough that are referred to specialists. These patients usually have a constellation of symptoms that include atopy, eosinophilic airway inflammation. They tend to improve with inhaled corticosteroids, and there is a potential for exposure to occupational allergens in these patients that starts the constellation of symptoms. These patients usually have an absence of variable airway obstruction or airway hyperresponsiveness. The differences are related to differences in the localization of mast cells within the airway wall. In asthma patients, the airway smooth muscle infiltration is where we see the mast cells. In our patients with non-asthmatic eosinophilic bronchitis, the mast cells usually infiltrate the epithelial cells. These patients are diagnosed with an induced sputum analysis after being able to exclude other causes of chronic cough. They are treated with inhaled glucocorticoids, which do tend to improve their symptoms. There was a review with 3 randomized trials, which included a total of 56 participants, that found that there was improvement in the cough visual analog scale, or the cough frequency score, in these patients when they used inhaled corticosteroids compared to placebo. They found that the severity of the cough, as well as the severity to capsaicin-induced cough, were both improved. They have not been able to determine an optimal dose or duration of treatment, but they do recommend starting somewhere in a low to medium dose of inhaled corticosteroids, and to continue for at least 2 months in order to reduce the risk of these patients relapsing with cough. Next slide. The next cause I wanted to discuss is upper airway cough syndrome, which is sometimes abbreviated in the literature as UACS. This was previously known as postnasal drip syndrome. There are multiple etiologies From this: allergic, non-allergic, vasomotor, acute nasopharyngitis, and sinusitis. The exact mechanism for how this causes a cough is unclear, but it's thought that it may act for a trigger. Again, we talked about this earlier on, that even low levels of exposure to allergens or to mucus or to something is enough to trigger this cough reflex and this cough hypersensitivity patients. The most effective therapy for these patients are intranasal corticosteroids. They are also effective for several types of non-allergic rhinitis. They usually work pretty quickly, within a couple of days, to reduce the cough, but up to 2 weeks to achieve their maximum effect. And you can continue this until you can identify what their trigger is and then either minimize or eliminate their trigger. Non-sedating antihistamines, things like Zyrtec, Claritin, Allegra, show mixed results. They don't tend to work quite as well as what the nasal corticosteroids do. Excuse me. If you suspect that this is a non-allergic cause, some of the other nasal sprays can work as well. Things such as azolastine, corticosteroids, or ipratropium. We see that ipratropium does reduce rhinorrhea that is associated with non-allergic rhinitis, and it seems to work quite well. So that's always one to consider. The nice thing that I like about ipratropium nasal spray too is that it can be taken a little bit more often. Patients can use it up to 3 times a day, which they seem to like, because for some of these patients, every 12 hours seems like a pretty long gap between taking medication. So being able to add a third dose and taking it a little bit more often seems to give them a little bit more relief. Whether that's placebo or true, it does seem to work a little bit better for them. So they sometimes like that, having that option. If patients do not improve in 1 to 2 weeks, that usually is able to rule out upper airway cough syndrome due to allergic or non-allergic rhinitis. If there are nasal symptoms or signs present, you can consider a CT scan of the sinus before completely excluding upper airway cough syndrome as a cause. So you've treated them, they haven't improved, but they do have, nasal congestion, they've got sinus tenderness, they've got, possibly some purulent secretions. Consider doing a CT scan, because they could have a chronic rhinosinusitis that's contributing and is just not able to be fully treated by the nasal sprays. So fully ruling that out before discontinuing treatment is always important. Next slide. So gastroesophageal reflux is another very common cause that we see a lot. These patients are generally treated with lifestyle modifications, things such as weight loss, elevating the head of bed, stopping smoking, avoiding medications that provoke their reflux, avoiding acidic beverages, and avoid eating 2 to 3 hours before bed. This diagram here is really important. Patients are like, oh yeah, I'm sleeping on 2 pillows, but my reflux hasn't gone away. It's important to remember that really what they need to do is they need to elevate the head of the bed appropriately, whether that means putting a block under the front of the bed to raise the head of the bed 8 to 10 inches, or to put a wedge under their pillow that raises the head of the bed 8 to 10 inches. Just sleeping on 2 or even 3 pillows is often not enough to really treat these symptoms. The other thing that you can do is treat them with acid suppression medications. You can start an empiric PPI at a moderate dose and continue this for 1 to 2 months. If there's no improvement, but they really truly have symptoms of reflux, consider 24-hour esophageal pH probe monitoring for these patients. Next slide. Post-infectious cough, especially this time of year, especially over the last couple of years, is very common. We see this from postnasal drip. We see increased bronchial reactivity. We see cough receptor sensitivity. If postnasal drip seems to be the cause, treat it the same way that you would treat upper airway cough syndrome with intranasal corticosteroids. You can also consider a first-generation antihistamine. If patients have a cough that's associated with a common cold, they tend to be a little bit more sedating, but they do have stronger anticholinergic effects for these patients, especially if this cough is bothersome and keeping them up at night or preventing work, or again, causing syncopal episodes or something, a little bit more severe. And those include brompheniramine, chlorpheniramine, clemastine, and doxalamine. Some of these patients will have airway hyperreactivity and can have a positive methacholine challenge. These patients may benefit from albuterol. If there's no evidence of airway hyperreactivity, you could also consider ipratropium. There was one study that showed that included 14 patients. 12 patients improved with ipratropium, and 5 actually saw complete resolution. So don't rule out ipratropium as a possible treatment for these patients. Next slide. Bordetella pertussis. There are some studies that estimate that it may be responsible for up to 20% of post-infectious cough in our adolescents and adults. The cough for Bordetella pertussis, it's called whooping cough. It's a very, very classic cough. Once you've heard it, that's what it is. There's inspiratory whooping or a post-tussive vomiting seen in these patients. Antihistamines and beta-adrenergic agonists do not work. Antibiotics do not work to reduce the duration of symptoms. And that's why, they are recommending boosters for some patients because they found that the initial series does not last, and patients need to be boosted against Bordetella pertussis. Excuse me, next slide. Talking a little bit about medications. Again, angiotensin converting enzyme inhibitors, ACE inhibitors. Treatment number 1 is to discontinue the medication. Usually in these patients, the cough will resolve anywhere from 1 to 4 weeks, although in some patients it may take up to 3 months. If you restart them on an ACE inhibitor, either the same one or a different one, they usually will see a recurrent cough. There is a suggestion, again, I mentioned this earlier, that an angiotensin 2 receptor agonist, or an ARB, as they're often called, could be a substitute. The incidence of cough in these patients is lower. There was a 2008 meta-analysis that looked at 29 trials that compared ARBs versus ACE inhibitors. The rate of cough with the ARB was 3.2%. The rate of cough with the ACE inhibitor was 9.9%. So the incidence is lower, but I still argue that it's not necessarily the best solution is just to put them on an ARB because they could still have a recurrent cough with these medications. There is a trial, or was a trial called the On Target trial, ongoing temelosartan alone and in combination with ramipril, global endpoint trial. What they found is that the cough was significant enough to require permanent discontinuation, and that this happened significantly less with telmisartan, 1.1% versus 4.2% with ramipril. So, if there are no other options, I think in ARB, you're going to see less of a cough, but keep in mind that not every patient is going to tolerate the ARBs without developing a cough. There is also a benefit of ARBs to patients with a prior history of ACE inhibitor-induced cough. This particular trial looked at 135 patients randomly assigned to either repeat therapy with an ACE inhibitor or to valsartan or to hydrochlorothiazide. Patients had a recurrent cough much more often with an ACE inhibitor, 67% versus 19% with the other medications. Next slide. Come to the category, which is the bane of every pulmonologist's existence, I think, which is unexplained chronic cough. These patients are thought to have an abnormally sensitive cough reflex, possibly due to alterations in their receptor ion channels, possibly transient receptor potential vamyloid 1 or transient receptor potential anchorin 1 are the 2 ion channels that are thought to be responsible for unexplained chronic cough. For these patients, you can consider non-pharmacologic treatment with things like speech therapy, breathing exercises, cough suppression techniques, which have been shown to improve severity and frequency of chronic cough. However, there's only a few studies that used validated cough measurement tools, so sometimes hard to quantify. They also looked at using empiric bronchodilators, such as inhaled corticosteroids, which help to decrease airway inflammation and may be dose dependent. We also mentioned earlier ipratropium, which blocks the efferent limb of the cough reflex. It decreases stimulation of cough receptors. It alters those mucociliary factors that may also contribute to chronic cough. Next slide. There has been use of gabapentin and pregabalin. These are gamma aminobutyric acid analogs, which bind to voltage-gated calcium channels and inhibit neurotransmitter release. It's thought to improve chronic neuropathic pain via a central mechanism. And the thought is that it works the same central mechanism to improve chronic cough. However, it should be noted that neither of these medications are approved for use in chronic cough, but they're investigative and they're looking into performing studies and looking at these medications a little bit closer to see if it could be an effective treatment. Opiates work on the central cough center. Morphine is able to reduce cough within a week in about 50% of patients. They do recommend a starting dose of 5 milligrams twice a day. And they find that morphine does have more predictable results than codeine when it comes to reducing cough frequency. There are some non-specific antitussive agents, specifically things like dextromethorphan or benzoate or guaifenesin, which are what we think of in our typical cough medications. The role is unclear. There's not really a lot of evidence as to whether it benefits these patients. But again, some patients do feel like it improves their cough. And so, as a temporizing measure while you're working through the causes, this may be something to consider. Next slide. There are some investigational agents. There's a P2X3 antagonist, and the thought is that there's increased sensitivity of these P2X3 receptors on airway sensory nerve fibers that could potentially cause this refractory cough. And these also can cause loss of taste and nausea. So that's one of the downsides to these medications. Thalidomide. There's a trial on patients with idiopathic pulmonary fibrosis, and it's thought that thalidomide has anti-inflammatory or anti-fibrotic properties, which help to decrease cough. However, most of us are aware of the serious adverse effect profile, including teratogenicity, that caused this medication to be pulled from the shelf in the first place. Nebulized lidocaine can reduce the frequency of chronic cough, but it is limited by its side effect profile. And then macrolide antibiotics. A lot of patients that have chronic cough have been found to have increased level of neutrophils in their sputum, and macrolide antibiotics have an anti-neutrophil property, which is independent of its antimicrobial effects. But although, in theory, this should work and should help to reduce symptoms, we have not actually seen that come to fruition in any of the trials. Next slide. So in summary, again, chronic cough is any cough that lasts beyond 8 weeks. It can affect 10 to 12% of the population and can have serious complications. It's thought that these patients with chronic cough have cough reflex hypersensitivity, where even low levels of exposure to dust, to allergens, to bacteria or viruses, just low level of exposure can trigger a cough in these patients. Again, our most common causes of chronic cough are asthma, upper airway cough syndrome, and GERD. The recommendation in general is to treat for one cause at a time, although some patients may benefit from treating for simultaneous causes with empiric treatment and then slowly backing off of one treatment at a time. Consider post-infectious cough, again, especially this time of year, and in COVID season, and especially bordetella pertussis as well. And then make sure that we're reviewing medication lists for possible causes or triggers on there that you may not regularly think of as a cause of cough. Next slide. I'm happy to take any questions. I think the last 2 slides are references.
Awesome. Thank you so very much, Dr. Sila. That was excellent. I'm sure people have many questions, so please use raise hand or just unmute if you have any questions for Dr. Sila at this time. No question? I know Dr. Doyle does, but we were just trying to give you guys a chance. He might strike up some questions as well. All right, go ahead, Dr. Doyle.
I'm not going first because I know that people have questions, and we have good attendance from the APHP Gracie and Dorney sites today. We got 5 out of 12. There's a bunch of respiratory therapists out there.
Go ahead, Dr. Stansbury.
Yeah, I guess I'd just bring up, like, what's the role in imaging? And I had to jump off for a little bit, but I don't know how much we discussed, like, someone with a refractory cough, if you get a CT at some point and when, and what's the utility?
And I want to piggyback on that question because that was one of my, and which is, especially after Dr. Sharma's talk last week, I started feeling like chest X-rays might become extinct, or 2 weeks ago, and so along with his question would be, in a case like this, is there anything a chest X-ray would be better for than a CT scan?
Well, I think a chest X-ray is an easy, quick modality. It doesn't require pre-authorization, and so it's easy to send a patient from clinic over to get a chest X-ray, which I think can rule out a lot of major causes. Can rule out a giant chest mass, can rule out a pneumonia, and some of those things. I think if there's no immediate concern on the chest X-ray, then I think you can proceed with some of these trials of other medications and other treatments to try and rule out different things such as upper airway cough syndrome or reflux or things like that. Again, I think sometimes once you've treated these patients empirically, especially if your history is pointing in one direction or another, but you're not seeing the hope to improvement, then I think sometimes additional testing such as CT scans of the sinus or CT scans of the chest may be warranted to look a little bit closer and make sure that you're not missing anything. A chest X-ray is not necessarily going to show you a foreign body all the time. So, there may be, if there's concern for an inner airway obstruction or foreign body or other subtle changes such as, the beginnings of interstitial lung disease, I think CT scan does play a role, possibly not, in the first couple of steps, but there is a role for CT scan imaging in some of these indications.
I did have an interesting case one time that, I ordered CTs, I don't know how many times for chronic cough, and it doesn't seem like they've been too helpful, but I do have one case where we actually found a tracheal diverticula that was kind of filling up with mucus and stuff and draining down and causing the cough. That's a pretty rare finding.
But it wouldn't be seen on chest X-ray, absolutely.
Right.
But how about the other way around, Rob and Allison? Can you think, is there any condition for which chest X-ray has greater sensitivity than CT? And another way to ask that question, is there anything that a chest X-ray would get and a CT scan would miss? And it's maybe no.
Yeah, I can't think of anything off the top of my head. I don't know if Allison can.
No, I can't think of anything either.
Okay, well, I have a two-part question, but one part is for the pulmonologists, and the other part is for the our respiratory therapists. And we got Aaron Erb, we've got Lisa Emery, we've got Dean and Sheila. I know you're not a respiratory therapist, but you've been showing up for MAN regularly. Thank you. So my question for the respiratory therapists. This talk is a great talk to generate case presentations, and I hope that we'll get some case presentations about chronic cough, because I'm sure those of you who are out there have patients like this. And so my question for you all is, do you have any patients right now with chronic cough? My question for Rob and Allison is about how many patients a year do you see with what meet the definition of chronic cough greater than 3 weeks?
Unexplained chronic cough?
Yeah, that was going to be my question, because I mean, I think about something like the ILD patients, IPF patients. You know, they have some of the most refractory kind of dry cough. It's
No, not unexplained. Start with the big group. You know, chronic cough that's at the top of your diagnostic algorithm, Allison.
I mean, you see patients all the time too. You know, one group that your COPD patients tend to have a chronic cough too, but we don't necessarily. That's not necessarily what I'm treating them for, just because it is a symptom or a part of their COPD, a part of their asthma. You see this a lot with your like Rob said, with your ILD patients, where they've got this chronic dry cough that every time they come in, and so we see it a lot. But I would say probably, I would say a quarter of my new patient evaluations that come into my clinic are for chronic cough.
Wow.
Yeah, I would say, I mean, something around that, because cough is such a common manifestation of so many pulmonary illnesses, right? So.
And I'll add to this presentation. I was asked to give this presentation for the state ENT conference at the end of last year. And so it's a big diagnosis, I think, that our ENT colleagues are seeing as well, to the point where they wanted a lecture specifically on this for their state conference. So it's not just limited to our pulmonologists, but also to our ENT, and absolutely to our primary care physicians and colleagues throughout the state too.
Yeah, definitely. And I hope ENTs won't take offense at this. They probably would if they were here. But my experience with our primary care referrals to ENTs for chronic cough is that there would be a quick diagnosis of GERD and they would just bounce them back to us. So I would pick the pulmonologist I'm sorry, even though it's the bane of your existence. But how about any cases out there from our RTs of patients with chronic cough that either right now or in your experience?
I don't know about everybody else, but it seems to me like, I mean, cough greater than 3 weeks right now. I mean, most people that are post-COVID are carrying on with a cough. I mean, a good deal longer than 3 weeks. I'm seeing them resolve, but or start to resolve. I mean, shortly, I don't know. But I just know that like if you've had COVID, a lot of folks seem like they have a cough that carries like way past 3 weeks, and it's just getting over COVID. I don't know. I'm not sure how much of a case study any of that is, but
I think we're seeing, 10 to 12 weeks is not uncommon, which is what I tell these patients that are post-COVID. And even, my chronic lung disease patients with asthma or COPD that develop a respiratory infection on top of their underlying lung disease, 10 to 12 weeks is not uncommon, unfortunately.
I'm a case, and my COVID was January 16th to about February 1st until I was test negative, but my cough, and I'm on a low dose of an ACE, but mine went on for at least 6 to 8 weeks. And let's see, right now I'm about, I guess I'm just about 8 weeks. So yeah, it was probably 6 weeks.
I have a case study I can share. Well, not really a case study. It's more of a personal experience, but 50 some, maybe 60 some year old female who developed a cough, had some type of upper respiratory infection, and just wasn't getting any better, was taking inhaled corticosteroid without improvement, was using nasal sprays without improvement, ended up getting sent for some pulmonary function testing, which showed a decrease in diffusion capacity. Excuse me. Once the results of those pulmonary function tests were received, was sent for a CT scan of the chest for some further evaluation, and was found to have some beginnings of some interstitial lung disease. They did a history, and she had worked as a hairdresser back in the 70s for about 10 or 12 years. There weren't a lot of regulations at that point, and a lot of chemicals being used and things like that. And so it was thought that was possibly the cause of her underlying interstitial lung disease. Continued to worsen, needed some supplemental oxygen. They did some additional rheumatologic studies. You'll have to bear with me because I'm going off memory here, and was found to have some other abnormalities. Was started on one of the biologics for ILD. I can't remember if it was OFEV or Esbriet, but sort of stabilized at that point. And then once some of these other rheumatologic testing came back, was started on another biologic, and has actually seen some improvement and actually some reversal of some of the underlying lung disease. So a little bit of a complicated case. I'm not sure whether this is all occupational related or whether there's some other underlying conditions. The improvement that they've had with the treatment makes you think that this is not just occupational exposure. But you can see it's not an easy cut and dry solution. This is actually my aunt, and we thought that she had just a post-infectious cough because she had been sick for about 3 weeks and just wasn't getting better. This cough just hung on, and that's what we thought that it was. This was prior to COVID. This was 2018. But it's not an easy answer. There's lots of different, confounding factors that can come into play, even with a run-of-the-mill case or what we thought was a run-of-the-mill case. So
Thank you for sharing that. Anybody have any comments or questions with that?
Well, before you jump into your evaluation, Elizabeth, I just feel like this is a really, really great presentation. I don't think I've ever heard a presentation on chronic cough before, and yet we deal with it so much in primary care. So hang on to it, and I would nominate it for your annual list. And I guess, and one other quick thing. So Allison, did you already have this talk in your briefcase before the ENT request came? I'm curious about the history of how you came up with it.
I did not. One of my friends from residency was the president and in charge of getting speakers for the ENT conference. And he called and had asked if I would be willing to give a presentation. And I said, sure, what do you want? He said, chronic cough. And my face, I'm sure, dropped and my heart dropped. And I'm like, oh, I hate chronic cough. But, it was, I think they seemed to get a lot from it when I presented. It was very well received. But no, this was a new thing for me to present on. So,
as a pulmonologist and a mother of two, with a household full of sick people right now, I think another version of this that would be interesting would be in children. And quickly, what's your differential of the most common in children? Because we see that a lot in primary care too, kids who won't stop coughing.
I don't treat a lot of kids. Excuse me. But I think for a lot of these causes, it's pretty similar. I think post-infectious is probably the most common. We do tend to see a lot of allergies, especially in this area. I think asthma is another common cause. So I think a lot of the causes are the same. Kids can even have reflux, although it's a lot less likely. But I think probably infectious is going to be top of the list for kids.
You want to mention what you just posted, Rob?
Yeah, that's just an ERS guideline, European Respiratory Society guidelines for the diagnosis and treatment of chronic cough, and it has some PED stuff in there.
Thanks.
Excellent. Thank you so much. I'll include that in our post email. Well, I'll pop up that poll. You guys can still discuss, but whenever you are done with the poll, you're welcome to leave. We really appreciate it. Our next session is April 3rd, and it's going to be discussing work-related asthma. So let me just pop that up there.
Now, I thought I was supposed to be presenting the gold guidelines on April 3rd. Did I mess that up?
I apologize, Mitra.
So we are doing a collaboration with the occupational medicine residents